This is the workshop part of the workshop. And this is going to be, we're going to turn these teaching points into a conversation now. And the next 30 minutes or so, we're going to show you two different videos of a student or resident being taken through a laparoscopic cholecystectomy. And there are two different videos. They're about 6 minutes each. And they demonstrate, some in good ways and some in more challenging ways, the concepts that you've heard here this morning in both the brief, the dialogue, and the debrief. And we want you to analyze that. And we're going to have a conversation about the things that were done well and the things that perhaps could be improved, challenges that you see the instructors in these videos have that you may have in your own operating rooms, and discuss strategies of how to improve your own skills, all of our skills, which we can, with shared tactics and techniques. So we would also like to do a little role-playing with this. And while I'm not going to pick on anyone individually, but if we could get you into groups of maybe 5 people or so, if you can kind of maybe just find the folks around you. And what we're going to do is have you analyze each of these videos for some of the discussion points that we looked at. The first video is missing a debrief, and so after you've analyzed the setup and the dialogue for the first video, have someone play the instructor, someone play the student, and just determine how you would conduct that debrief based on the conversation that you just saw, the dialogue that you just saw. And each of our instructors are going to go through we'll take a group and have a discussion, and then we will come back and have a central discussion about it. Then the second video, which is the same operation and the same skills, but a completely different conversation, as you'll see. Yeah, I was going to put them in groups first. So nobody wants to sit in a talk and start having to move and talk and discuss, me least of all, but really the benefit that you will get out of this session if you actually, having now learned how to fish, actually start fishing is going to be higher in magnitude than just having listened to this and taken off. So if I could put one faculty member on each group. How many groups? Are there any groups of 4 or 5 that are missing a faculty member? Have one? Okay, Amy, great. Do you guys, Dimitri, thank you. And on that side of the room, you guys need a? We're going to do the video. So each group needs to assign a trainee and a trainer, and the others will observe and make their analysis and comments about that interaction. Good. We ready to roll? No, after the video we'll stop. So we'll watch the video and then we will stop, break into our discussions, and then for just a few minutes, and then we will bring all of those ideas forward as a central discussion. Figure out how to.
So it looks like our goal for this portion of the operation is to clean up the duct.
They're having the brief off screen.
Divide the duct, and then take it off the gallbladder. Any thoughts or concerns or questions about how you plan on going about that?
No, I think you just need to focus on, like you said, cleaning up the duct. I'd like to avoid any injury, obviously. Want to continue to focus on using the cautery in a safe manner, and obviously just finding the right planes.
Okay, how do you want to clean up the duct? Let's get started. Are these supports you've been using?
Yeah.
Okay. What instrument do you want to use?
So
to
we've
clean
been
up the
using
duct?
the cautery, I think, to find the plane. I think we might have a little more.
Am I with you today, Deb?
Yep.
Before I.
Awesome.
It's a little loud.
How's
Turn
things?
down the music and try to talk a little bit less unless it's
Yeah.
urgent for the patient.
I'm just trying to get, settled into the room here if I can.
Thank you for your help.
Yeah, no problem.
They get you there.
Okay, hang on one second.
I like that lateral motion there. That's great. Redirect it. Just so you know, if I tell you to stop, it doesn't mean you're doing anything wrong. It's just maybe we see something gorgeous.
Okay.
If I tell you I love it, it means keep going.
Okay.
So show me where you want to clean up the duct. What's your plan?
So I want to clean up here, down a little bit further.
Maybe even a little bit more needle where you can see it. You see where it's nice and clear in that window? That's
Right,
right in
yeah.
there. Yeah, a little hook and a little burn. I love it.
Okay.
All right.
Nice. Yep. So our goal here is to expose enough to the duct that we can really get some clips on, right? So what might be two of your goals as you're doing this, which I love? Keep going.
Clean the duct up, find the artery, clear off a lot of this excess peritoneum.
Yeah.
Come back up to that clear space again where you can see it's giving it to you. I love it. Gorgeous. Now what do you think about that? Is that enough length on the duct?
It's probably not enough to get close to the artery.
Okay, great.
I'd like to find the artery over that.
Well, I think they're together. We're going to separate it
Oh,
over.
do we, okay.
Looks like we could probably get it across. I'm not sure about this anatomy.
Right.
If they wanted us to separate them out or clip them together.
Okay.
I think we clip them together. So I think we have a
Okay.
sufficient amount of length. Let's look at the clip applier. Do you know how to use this piece of
Yes,
equipment?
I do. Can I have the clip applier, please?
Can we have the clip applier,
Oh, really?
please? Yes, ma'am. Thank you. Do you think maybe you could stay over here to kind of help us on this side of the table? So show me how you're going to use that.
Okay, so obviously when you get the right angle, one of the things that I've been taught, I'm not sure if this is the right thing to do, but is to get around the duct and the whatever you're going to clip and bring the tips together so that you can see them and then fire the clip.
Love it. Sounds like a great plan.
You guys could let me know when you're cauterizing.
Sure, we'll do.
And if you see any bleeding or anything, let me
We'll
know.
let you know. So why don't we focus technically on you getting nice and around the duct and firmly placing the clip, right? You don't want them to fall off. Can't quite see it around there, but maybe pull your hand a little anteriorly with your left hand so we can see what you're around. And roll it over a little. Perfect. So stop right there. You can see it, right?
Yep.
We know what we're around. We know there's nothing terrible in the background,
Yep,
right?
yep.
Understood. All right, go ahead. Let's see. Wonderful. So it's important here to not crisscross your clips, right? We don't want to be crisscross applesauce. That's painful. So really visualize where you're putting it and confidently flip it down.
Right?
Yep. Great. Now I would come out so we can really see our two clips. We love them. Right? Maybe move your left hand up a little bit so you can get that top clip really high.
Okay.
Can you see?
Mhm.
You like it?
Yep.
I love it. Go ahead.
Hey Deb, can you go grab me an LMA?
Hang on 1 second. Stop.
Yeah.
Anesthesia, we having an issue?
Oh no, I just I'm gonna like swap out airways.
Would you like us to stop and do
Oh no,
again?
you're good to go. Can carry on.
Maybe we could wait to swap out the airway. We're about to divide the duct.
Okay.
Okay, perfect. Go ahead.
I just want to have it just in case.
So I'm kind of slide up and rotate it out. Yeah, exactly. If I see around it. I can see that. That's perfect. Now rotate to the right. I love it. How do you feel?
Good.
Good. Okay. So now with the scissors, you don't want to jam them right in there, right? So
Nope.
that's how you're going to reintroduce a sharp scary instrument.
Keep them closed all the
Thanks.
time, and then I'll follow them in from as soon as they enter the port.
Perfect. Can we have the scissors? Where do you want to divide the duct?
In between the two proximal clips and the third distal clip.
What do you think happens if you divide the duct too close to the bottom clip? What could be a potential problem with
If
that?
the bottom clip will slip off, you get a cystic duct.
Right, then we're unhappy, so don't do that.
Okay.
All right.
There we go.
I think it's fine to just divide that. Great. All right, so now what are we going to do?
So now we need to free the.
Have you seen my anesthesia tech around here anywhere?
What column?
Cool.
Problems?
No problem.
Okay.
With the card, with the electric card,
What are you asking?
should I free up the gallbladder? From
Yeah,
that?
but it's going to be a great plan. How are you going to start? You already have it mobilized kind of anteriorly. What's your plan?
So with tension, I think I'm kind of creating a plane there.
Yeah, I can kind of see right there, right?
There, yeah.
And maybe start with a little hook and pull instead of back ending it.
Okay.
I feel like if you back end it, I would hook the other way. Turn your hook around.
Okay.
And hook and pull towards us, not up there. Down here where it's like giving it to us. Right
Right
there.
here.
Yeah, hook and pull. If you back end it too early before you can see, you might get right into the gallbladder. We don't want to do that.
Okay. Can we go with this again?
Looks great.
Yeah.
Okay. You watched the brief that took place off camera where they discussed that his goal was to, quote, learn how to do a lap chole. And then you watched some of the dialogue. You didn't see a debrief. What I'd like you to do, if you've assigned roles, is to evaluate those two sections of what you saw for the items and the instruction areas that you saw in the previous lectures, and determine whether you thought there were things that could be done differently, whether you would challenge the techniques that were used by the instructors. And then I want you to play out a debrief of how you would debrief this session if you were the instructor and someone plays the trainee, and I want the other members of the group to evaluate how that goes. And then we'll do that for a few minutes and then have a central discussion about all of these points. Why don't we wrap up, take another minute or two to wrap up conversations, and then we'll get going. Let's, can you guys hear me okay? Can everyone hear me okay? I don't want to stand up at the podium. Let's have a conversation about this. Are we all finished up with, I heard a lot of great discussion about this, and I think a lot of you guys have already tagged on to some of the obvious points, and we'll talk about maybe some more of the subtle points. So we didn't hear a lot of the briefing. It occurred off camera, and it's always tough with the videos to try to get all the words and pieces to it, but hopefully you were able to get the dialogue. And judging from the conversations I heard, it sounds like everyone was able to absorb what they were listening to. So let's start with the obvious. I want to learn the steps of a lap chole. How's that for a goal? Way too broad. So how many of the 5 points of a goal does it meet? Is it realistic? Somewhat. To learn the whole procedure in one setting may not be realistic. Time. Well, you do it within the distance of the time. How about agreed upon? Why no? Yeah, we didn't hear that conversation take place, and while the goal may sound simple enough that everyone agrees you want to learn how to do a lap chole, it may not be the instructor's goal that you learn this entire procedure in one setting versus learning specific parts of it. And then, obviously not specific enough. Any other thoughts about how that could be pared down to be a better goal? And I guess I'll ask, is it a measurable goal?
For example, whether cystic artery is correctly identified, whether dissection is done properly, where the clips are placed. There is many ways to actually assess, and the best paper is written by Dr. Singh.
So each part of it can be measured, but that's a lot of goals and a lot of things to measure in one setting. So when we get to the back end of the debriefing and take-home messages, that's an awful big goal and a lot of small measurable parts that have to be measured in one setting. And that may take it out of the realistic realm of what you can accomplish in one setting. Any other thoughts about the briefing on this?
I think it's very important to know at what stage the learner is, because then it's much easier to set incremental goals. Whereas if we don't know what level this resident is or this trainee, and
We-
whether they've done anything
I
before.
want to repeat that, John, because I'm not sure.
He,
Sorry,
yeah,
sorry.
he said it's important to know, we never heard her ask him, how many of these have you done? How comfortable are you with what you're going to do? It could be his first, it could be his 100th. We don't know whether she's operated with him before. I think some of the dialogue gives us a hint as to where he is on this scale and where her comfort level is with him. We're going to get to that discussion in a second, but his point was she has no idea where, and so that certainly plays into what realistic goals are going to be setting out, rather than how many people here get the same resident for every case for weeks. Yeah, right? I mean, we're at the point now where you may not even get the same resident for the whole case. We're at that level. So you don't know. You may know, but you don't want to guess, you don't want to assume. Right.
I think it's a great point. And one of the things that it does is that, to me, this is one of the most important parts about resident satisfaction for the case. Because if we elicit objectives from the resident, and we agree on them together, and it might be, like I said, this is the first year, then our objective is not to get you to dissect out your safety. Our objective might be, I want you to be able to separate the gallbladder from the liver and stay in the right plane for as much of that part of the procedure as possible. That way, when you have to take over a part, but you agreed already that you were going to do that part, then there's no walk of shame, as they say, from the other side of the table, right? Like, oh, I went from operator to assistant. Right. It was agreed upon ahead of time. And in the reverse, if they can't take the gallbladder out of the liver, and that was the objective, now we can have a focused discussion about why that was. Why couldn't I get you? We both agreed ahead of time that we thought that you could do that. It turned out you couldn't. And so what happened?
So let's go to the dialogue. Was this a instructor who was comfortable in silence? No, absolutely, you're right. Was there any silence? Was she throwing him the backwards alphabet while he was trying to flip the water bottle?
It was CBN,
CBN.
cut by numbers.
Actually, I think the whole environment was right.
Yeah.
Like not just her discussion, but that whole environment was, yeah.
Did you hear music through the whole thing? Did you hear her ask anesthesia to shut the music off? Did the music get... So there are layers upon layers of dual task interference here, correct? Multiple layers. So what can she do differently if you were debriefing her as an instructor in how she conducted that dialogue?
She could have briefed the whole operating room, or the whole room.
You said she could brief the whole operating room. You settle those issues before you start. What about the way she dialogued with him?
She can give him a chance, like ask him what is your next step before, like you say do that and okay with that, just to give him a chance.
Her point was, give him a chance to operate. This was all show and tell, right? Cut here, cut here, cut here, cut here. So she really has no idea what his skill level is or what he will struggle with or where he has questions, because she never bothered to stop to elicit his feedback or just watch him operate and see where. Now, of course, safety first trumps all of this, but the idea of the briefing is to determine what level you're at and what you're comfortable at and what you're not comfortable at. And did she use the word stop? Did she instruct what stop meant? So she did, but while he was starting, she was, oh, by the way, I might say stop to you, and that'll mean I want you to stop. That doesn't mean you want anything, that you've done anything wrong. So, do you think she had an effective use of the word stop? Were there, let me reshape the question. Were there episodes where she tried to instruct him where he just kept on going? Lots of those. Lots of those. Is that safe? The answer to that is no. That is not safe. She is stopping him for a reason. She's giving him instruction for a reason. That he's in the wrong plane, he's getting close to hurting something. And as Brian mentioned, stop can't mean 3 more steps after stop. Stop can't mean stop maybe, just listen to me while, stop means stop, and that's how you keep control of this operation. How, I think you're getting a little too close to the comment.
Yeah, get more too close.
Too close. Turns out I was right. There's a take-home point. We'll get to that.
Actually, one thing was interesting is that when she said stop and talk to anesthesia, he kept on. That was the scariest part.
So that's, you heard dinging throughout this whole thing. Who knows how this person was doing. And then the whole LMA discussion, and can you get me an LMA? As if the surgeon is not supposed to respond to that, to a discussion about changing out airways in the middle of the procedure. And to Brian's point, did anything stop? Did you hear buzzing while they were having a discussion about the airway? You did. And she actually, that was one time she did use the word stop. But did he stop? So if you're her in that moment, and you're now having a discussion about airway, and your trainee is continuing to wave the lightsaber with energy, what do you do in that instance? Stop. And if stop doesn't result in stop, then you have to have a stronger conversation, and you have to take a step back and realign what the word stop means. Because if you don't have stop, you can't continue to do this in a safe fashion. Yes.
I just want to say, though, that she set up the environment the whole way for him not to stop while she was talking, right? So the anesthesiologist from the beginning didn't do what she asked, and she kind of didn't care. Like, you know, the OR went on. So on the one hand, you have this perception that she's in control of everything, but on the other hand, the entire time she's talking, oh, a little left, oh, well, I would turn it the other way. And she's giving the instruction as, I mean, she's demonstrating, well, you should just be continuing because I want to get this over with kind of thing. So she wasn't, she didn't set him up to stop when she says, okay, stop, I'm going to talk to the anesthesiologist. She didn't set the precedent that he doesn't need to.
Everyone here? Any other discussions about dialogue, about the way that conversation took place? Yes.
I think, in the light of being a bit more positive about her experience also, what we also thought that when she did stop or say stop, she followed up with a question so that the trainee could get a moment to reflect and answer. And I think it sort of tied to the point made earlier on that it encouraged some confidence.
If you didn't hear him, his point was to be positive. It seems like it's all been negative. She certainly had moments where she said stop and then elicited some information. What do you think is happening? There were certainly moments like that. For the points of the teaching, we tend to switch to the moments where we can show how those conversations can change. But she definitely had moments where she stopped him and asked him what he felt was happening. So and that part was good. You're right. So we had some debriefs. We had some, and I heard some good debriefing. Let me have a volunteer to stand up who debriefed, or at least observed debriefs. Let me hear your comments on what you thought an effective debrief for this would look like. Anybody?
So, our group talked about the importance of goal setting and making sure that whenever you're setting goals for next time, like in the debrief, that it's kind of like multi-level. So there's a goal of next time, we do this case together, I expect you to be able to do this part, or you to take over this section, etc. But it's also, it should have a goal like under that of, and here's what you need to be working on in the meantime to get there.
Absolutely, absolutely. So, like John, I'm a simple guy. I have to have things simple in my mind. A debrief can always start with the same sentence. How do you think that went? It's a great start. Start with them. Don't go out there with your baseball bat and let me debrief you. Debriefing is a conversation. So how do you think that went? And it has to go back to specific goals. It has to be a psychologically safe environment for them to be realistic with you. They can't be intimidated by you. And then you sandwich. You get their responses. You then can give them your feedback. and then you have to elicit that they have absorbed your feedback. And then what do you do after that?
John, don't you think it's a little difficult to do a debrief when in fact you had no real measurable good goals to begin with?
It is.
I mean, so
He's exactly right.
You're debriefing then in this case kind of becomes the classic, oh, you did a good job.
Yeah.
Because that's really all it is. So we're going to do a job. We don't know what we're going to do.
So the
That makes it a
debrief,
challenge.
the debrief has to go back to your goals. The debrief, we set out to accomplish this when we started. How do you think that went? It's hard to debrief this. Jim was exactly right, because there were no specific goals. There was nothing measurable. And there's the two most useless words after an operation are good job. Spectacularly unhelpful to anyone. It's not specific, it's not measurable, it doesn't give any follow-up take-home points. So after you've been able to, assuming you address those specific goals and you get that feedback, you give that feedback, you get that response following eliciting their evaluation of how things went, prior to take-home messages, one thing we talked about here was, is there anything you can ask them about how your teaching went? So one of the things we teach with debrief is, how can I better do this for you next? Now, you're going to have residents who are, if you just ask them, how'd I do? Residents can be very reluctant to criticize you in real time, and you can't ask them that way. You can't say, how did I do? The way you can ask that is the way you learn. How can I help better next time we do this? What can I do to help your learning process and this information stick? So you're not looking for a judgment. You're making them the centralized part of the focus, and you're getting a debrief yourself on how you're able to better. Any questions about that? And then finally, what did we talk about? Take-home messages. How many take-home messages do you want to give? Take-home message. Very rarely, if there's an important second one, but you really want to focus on one take-home message. And again, with no specific goals, it's hard to give that take-home message, but it should relate back to the goal. And questions?
In the new environment where we have a student spreading multiple different residents throughout the day, or residents covering on different services, I see how this works really well when the residents on your service and you know them and you can set goals for time and build on each other. I find it a little bit more challenging on either they didn't know they were going to be in that room, or they didn't very much pace. So, what kind of advice do you give for setting goals in the beginning for that, and constructive feedback that's more than maybe that's not?
Thank you for bringing the second point up, which is a take-home message has to be specifically actionable. Can't be go read more, go practice. Those are not appropriate take-home messages that's built into the soup. Yeah.
Let's review the internal anatomy so that we can clearly identify perspective.
Right.
That's a very defined.
Work on rotating your wrist. Give them a definable, specific take-home point. Or for the procedure, work on finding this plane with this technique. The first part is a challenge, and I don't have a great answer, and I welcome any of the instructors in the room to pipe in as far as, other than they may not know the patient and they may just be thrown in the room. I think you still start with, the same assessment of, well, we're going to do this lab chole. How many have you done? What do you get challenged with the most? Now that you're here doing this case, what would you like to get out of it? What do you see as, and you can just start the conversation from there, but it is no question a challenge. John, you had your hand up then, Brian.
Yeah, I think the rebrief helps with that a lot, because you say, like, you want to get out of this, what are you going to do? And oftentimes, I think you can prepare for this, because I just got assigned this case or whatever.
Yeah.
I'm not sure. So it actually creates a way to have that brought up, and you can investigate the reason why.
Yeah.
And then it's a reason need to focus down on.
On a specific thing. Brian had.
I'd say two things. We use this set dialogue sometimes. This happens a lot, or either you're thrown in or you just don't get a resident. Now have a discussion about what it is you think we can get out of this case. We align our objectives are probably not going to do as much in this case as they might have said in the paragraph. But if you get them to come to us, they're not disappointed with it. You can always find out. There's zero point. And then when you debrief, if you're giving them a single take-home message, they can transport that from opinion to opinion. So I have a resident come in. They haven't done a call out of me before, but they've done it with one of my partners. And I'll say, well, I'm reading a lot of so many of those. What was your take-home message the last time you did it? I'll say, well, we would work on that. So what do you want to work on? Well, I think I'm ready to do that. So I can see the transport from one to the next. It gives them the continuity that they used to have by doing that with many mentorship, where we had the same person over. So I found it even more important now.
We're going to watch the second video in the interest of time. The last thing I do want to mention was a great question over here. Who's involved in this debrief? Is this the room? Is this just you and the resident? And I think the right answer is that for the purposes of what we're teaching, this is just between you and the resident. You don't want to, they're going to be much less likely, going to go much further into their shell if you start involving an audience for this debrief. Take them outside the room after you've written orders, walking to the waiting room, or just as they're waking the patient up, whatever clinically the safest place. It can't be too far time removed from when the events occur, though. That can be separate from a room debrief, and we all do room debriefs and patient debriefs, and there can be things that happen that involve your team that can be a separate debrief with the team related to the same things, but that has to be distinct and separate from the debrief that you use for your residents. Did you take? Okay, we're going to watch video number 2, same case, different trainee and different instructor and very different conversation. Because in the interest of time, I think we will just go straight to we'll just have a group discussion about some of those differences.
Okay, so I have the Bovie, and I need to go grab in the gallbladder. And I'm just gonna get my instrument in there, a little J hook, and then I'm gonna start Bovie right here.
All right, sounds good. Show me what you got.
Okay.
Can you guys hear okay?
I'm just gonna.
Okay, so why don't you stop for a second?
Okay.
So instead of that sawing motion that you're using right there, what's probably a little bit better is to try and get that shimmy underneath a little plane of tissue that you can see through, and then hit that button to come through just that, so you don't perforate a hole in the back of the gallbladder.
Okay, can you define shimmy for me?
Yeah, so what I mean is to slide it underneath that little plane of tissue right there.
Yeah.
You're trying to, it's kind of tough to point with the camera.
Yeah.
Yeah, there you go. So.
And then shimmy, you mean like?
Yeah, kind of move it back and forth until you create a little bit of space in there. See how you can see your instrument right there
Yeah,
underneath?
but not soft.
Yeah.
Okay. Okay, so I'm gonna start now.
Uh-huh. And again, I don't think you have to make that motion with the...
Oh, so don't move. Oh,
No. There you go. You're okay. All right, why don't you try that again? So come back in with the hook, kind of come underneath that little plane of tissue. And then hit the button when you're ready, and you can see your instrument underneath it.
And is it a lot of like off and on?
It's a lot of off and on, yeah. Because if you sit there and hold that button down on the gallbladder, you're going to end up poking a hole in it. And we're trying not to do that.
Okay, so I'm gonna like bogey, like on and off a lot.
And when you get good enough, once you kind of become comfortable with planes, you'll be able to deal with sort of the back of the instrument and just come through that plane without having to lift up that plane like I'm having you do here.
Okay.
But as a novice learner, I think that's probably the easiest way to show you that plane without doing it myself.
Is it okay if I pull it towards me?
Yeah, absolutely. In fact, I
Okay.
wanted to pull it towards you. I'm sorry, I didn't say that. All right, again, let's stop for 1 second. Don't hit that button until you have actually kind of gotten to the thing that you want to burn.
Okay.
That's one of the risks here is that you could potentially move that thing somewhere that you don't
want it to go and hurt something that's important. All right. Yeah, there you go. Very nice. Excellent. Pull a little bit more from right here. There you go. And again, a little bit more control. I know I told you to pull there and you got a little bit hard, but that holding onto that button and letting that fly off screen like that, you could hurt something that we don't want to hurt. So
Gotcha.
try not to do that. Very nice. Yeah.
Do I need to reposition to get it back?
Yeah, why don't we reposition? In fact, we need to look at the other side of the gallbladder. So what I'm going to do, we're going to pull the camera out so we can all see. And what you're going to have to do is grab that bottom part of the gallbladder like you had at the beginning of this, flip it over, and we're going to try and do this on the back side of the gallbladder.
Tricky.
So yeah, you probably have too big of a grip on your left hand. So take a little less tissue and try and put it the whole way over. Yeah. Give yourself a little starting point there.
I'm going to both in.
Okay. Stop for 1 second. So you see how your two instruments are touching right there?
Yeah.
That could be, you're essentially grounding out. So the current is going from your right hand into that metal piece on your left hand and going to the rest of the tissue. So you want
Should I
to
start higher?
Yeah, you can start higher and give yourself a little space to work right there. Alternatively, before you keep going, you can start lower and create a little flap down there where the tension is going to be.
I'm not sure what I should do, lower or higher.
Yeah, so why don't we do this? With your left hand, why don't we reposition you a little bit and grab a little bit lower.
Right here?
And then hold that out. And it's not really giving us much.
Yeah,
Right there where it's
here.
kind of coming across. Yeah, go ahead and
Over
do that.
there?
Yeah, for sure.
Okay. How close is too close for these to get when it's on, the
As long
Hoki's
as
on?
they're not touching.
Okay.
Okay. See what you just did there?
Yes.
How do you feel about that?
I'm freaking out a little, I'm sorry.
All right, we'll move over and take another case.
Okay.
All right, well, fine. Let's let you keep going here. Okay, so why don't you grab the bottom of the gallbladder there?
Okay.
All right. Let's keep working on this side that we were working on. Yeah, there you go. Go ahead and keep doing what you're doing.
I'm going to try to grab a different spot. A little higher.
I'm not sure what you're doing here if you're working.
Okay, well, I feel like I'm making some progress, so. Look. Can you turn it on? So I think I can do it here. Is that?
Yeah, I think that's fine. All right. So where do you think you're at right now? How do you think this is going to go from here?
So I think I have pretty good progress up here. We flipped it over. I started to go this way. I wasn't quite sure what to do, but then I came down here. What am I doing
I
wrong?
think this is just. You know what? I should probably just see what this case.
Can you help me understand why? What I did wrong?
So I think a part of the. So what I saw was you were voguing almost willy-nilly, and I don't think you can quite see the planes just yet. And I think that'll come with experience. Hence, you got into the gallbladder.
Okay.
Does anyone in this room have as much patience as this guy had? So what was different about this dialogue than the last case? So maybe a less experienced trainee. How about the way he dealt with her? Did he stop her and ask her what she thought she was doing wrong? I see nods. I'm sorry? He embraced the silence. Yes. There was a lot, much more comfortable in silence. Would you agree? It was hard to watch sometimes.
No, it is.
As the whole screen goes up in flames. Yeah. So he was definitely patient, and he let her move along and stopped her when he felt. I saw a hand. Yes.
I think the concept of psychological.
Everyone here? That comment? So yeah, he definitely creates an environment where he's not aggressive or threatening with her at all, and she has the comfort to say that. But that certainly could have gone very differently, very quickly for different types of absolutely. So he mentioned the timing of, I mean, he didn't take over the case until the very last few seconds of the video. But within the 6 steps that you saw about the dialogue, what step at the end dictates that dynamic? So, we have take-home cards.
Yes, so I can give it to you when we leave, but I have specifically 27 of them. So if you don't think you'll use it, don't take it. But it's just a little badge or a little kind of something to put on your little badge at work, your hospital. And it has the 3 phases of intraoperative instruction on this side, and then the 6 steps that Dr. Duncan talked about, stop, inquiry, et cetera, on the other side. So I'll be over there at the door at the end, so you just grab them.
Would you mind if I just ask a quick question while the experts in the BID method are up there? And that is, most of the time I'm in the operating room, there's not one learner. You know, there's 2, sometimes 3, right? You have your intern, you have your medical student, you're supposed to be teaching both of them. You have your 3rd year that comes in, right, with the case about to start, wants to do it. Can you give some tips for trying to do this type of model when you have multiple learners?
Absolutely.
So yeah, so that's a reality. You know, what you do, what's useful about the brief is that learning objectives for each person.
Can you guys hear him okay?
So
Yeah, John.
So you set learning objectives for each person. So I go to the resident, so what do you want to learn? I'll say, well, I want to learn. Well, okay, we'll concentrate on, say, we'll concentrate on identifying the SAC and testing it.
So he was saying that you set different objectives for each learner. That.
In terms of medical students, what do they want to learn? The most common response I always get is, I don't know. They don't make it because they're not used to it, right?
Right.
They say, well, no, I really want to learn the anatomy. What part? Say, oh, they want to learn more about now. So we'll concentrate on that. And you identify two very specific objectives that you really concentrate on. And you get I do the same, and I do it at the timeout. So, because the residents are never there at the scrub, so we don't really scrub anymore. We're losing, we don't have that ritual ahead of time. So I do it at the timeout, and whoever's at the table, we're going to set objectives. And sometimes I have trainee scrubs and techs. We'll set objectives for them. So and it doesn't take as long as you think. It takes less than 5 minutes to do it.
Dimitri.
I wanted to make the comment that the usual practice that we ask the student questions while the residents do the procedure is distracting the resident because they know that the next target the student cannot answer. Right? So you should avoid that even though it's something you don't like to do.
Unless you set,
Focus on the learner.
unless you set the 3 objectives, I'm not going to ask you any of those.
But you still distract them.
Yeah.
By the question.
I-
Focus is meant to learn.
Yeah, no, it's exactly right. It goes back to what Brian was saying earlier about teaching and driving this process at the same time, that it is dual task interference. And traditionally, we've always had that model, but we really need to work away from that and do one or the other at any given time, but not both at the same time.
Outside the case. The debrief or timeout.
And you can answer a question during the case, but it has to be at a stop point. It can't be a dual task interference. I know that sounds like it does sound a little unrealistic, but only if you allow it to be unrealistic. And you know. Oh, I see.
or the interns if you're not talking during the case. Unless you have a division that's not worried about getting 6 cases done in a day.
But the point I'm making is that essentially what you're doing, what we all doing, I do the same thing, but I just realized not what I have to do, is you are putting your efficiency ahead of the learner's best interest. You realize this? So, because I'll save more time if I do it while I'm operating. I don't need to take extra time to teach them outside my operating. But that's not the best interest. They cannot learn because they cannot do this flow tasking as efficiently.
I would also say that this method of specificity helps with that level of efficiency, that you're not taking the time to teach them everything about laparoscopic cholecystectomy, that the teaching you're doing is the specific points you agreed upon that you were going to work on that day, and that closes down that conversation.
I would agree for an individual learner. I think when you have 3 learners in the ring, that's where I
Yeah.
think this is.
Yeah, and you may have to triage that. John, you had one last point. Sorry.
Move to the next part of the session. Hey, thank you everyone for the excellent discussion.